All right, well, I, acting as chair, Shelley Bailey, call the Prescription Drug Affordability Board meeting of February 21st, 2024 to order at 9:36 a.m. Pacific. Melissa, if you could please call the roll.
Akil Patterson will be joining shortly. Acting Chair Shelley Bailey,
Present.
Dr. Amy Burns,
Present.
Dr. Dan Harta,
Present.
Mr. Robert Judge,
Present.
Mr. Christopher Laman,
Present.
Mr. John Murray.
Present.
We have a quorum.
And Vice Chair Bailey, if you would, with your permission, I would like to go ahead and introduce Chris Laman, our new board member, and begin our process of electing a new chairperson following Akil's resignation last month. And as Melissa mentioned, Akil will be joining us momentarily if he gets through a technology challenge.
Please do. I do want to mention, Ralph, I see that John Murray has his hand raised.
Yes.
Thank you, Vice Chair Bailey. At this time, I need to declare a potential conflict of interest as an owner of Murray Drugs, and under advisement from the Ethics Commission. That's something I need to do because I have contracts to provide pharmacy services to public and private insurance companies. Thank you.
Thank you, Mr. Murray. And Ralph, if you will, please proceed with guiding us through the nominations for chair.
Sure. Thank you, Vice Chair Bailey. Before I do so, it brings me a lot of pleasure and satisfaction to welcome Chris Laman to our board. Chris just went through the Senate confirmation process in the last month and was appointed by Governor Kotek. Just a little bit about Chris as we look forward to him joining us. Chris is a doctor of pharmacist and pharmacy practice and an MBA. He is the Vice President of Strategy at Columbia Memorial Hospital in Astoria. He's been with the hospital since 2006, serving as the pharmacy manager and director of pharmacy and cancer center services. Chris is also a third-generation pharmacist, following after his grandfather and father, who ran a chain of community pharmacies. Christopher himself has opened 2 retail pharmacies, a 340B program, and a cancer center pharmacy. He also worked throughout the COVID pandemic as the incident commander for the COVID vaccination task force in Clatsop County. His experience in a broad range of practice settings, as you have heard, will allow him to bring a unique perspective and value to the board. We are very excited, and board members, please welcome Chris Laman to the board.
Welcome, Chris. Thank you for serving.
Welcome, Chris.
Thank you, guys. It's a pleasure to be here, and I look forward to being part of all this great work that you guys have already been doing for the last year and a half.
Looking forward to it.
Thank you, Chris. Thank you, Chris, and thank you, Vice Chair Bailey. All right, with that said, as committee members know, and I know Akil will be joining shortly, following Chair Patterson's resignation last month as chair after 18 months of great service, we do need to nominate a new chair. So I will be facilitating that process today. Process is as follows. Members may nominate themselves or another member. Once nominations are received, I will ask if there are any other nominations. If none, Vice Chair Bailey will formally close the nominations and we will call for a vote. Melissa will call the roll for each nominee. Members will say yes or no. The nominee with the highest vote count will be elected chair. In case of a tie, there will be a runoff. I will announce the new chair, and I believe we will have that person serve formally beginning March 20th, as Vice Chair Bailey will facilitate today's meeting. And if I may express out loud, I will call for motions at this time. Are there anyone interested, board members, to serve as the position of board chair, or would any individual member like to nominate someone else as board chair? I see 2 hands. I think I saw Robert first. Robert, go ahead.
Yes, I'd like to nominate Shelley Bailey as chair. She's done a stellar job as vice chair.
Thank you. And Dr. Burns.
I was going to do the same thing. So I nominate Shelley Bailey.
All right. And any other board members wish to either nominate themselves, appoint other persons, or if not, Vice Chair Bailey, is that a nomination that you would accept, that having been seconded? Should there be a vote?
Thank you for asking, Ralph. Yes, should there be a vote, that would be a role I'd be willing to serve in that capacity.
All right, procedurally, I think we have followed prescribed rules and processes. If no one else is interested in nominating or serve, Melissa, if you would please call a roll, and this will be a vote for the nomination of chairperson for the Oregon Prescription Drug Affordability Board for current Vice Chair Bailey to become the chairperson of the board.
Amy Burns,
Yes.
Daniel Hartung,
Yes.
Robert Judge,
Yes.
Christopher Laman,
Yes.
John Murray,
Yes.
Vice Chair Shelley Bailey,
Yes.
and I don't believe Akil arrived, so the motion passes.
All right, if I may be the first, I am thrilled, Shelley, to congratulate and welcome you as the second chairperson of the Oregon Prescription Drug Affordability Board. As the executive director, I'm very excited and enthused to be working with you going forward, and I think that under your leadership, this board will continue to accomplish great things. So congratulations on behalf of the board. With that said, board members, there is now a vacancy for the vice chair position that will be vacated by our new chair, Shelley Bailey. With that said, I will go ahead and continue with the same process.
Ralph,
Yes,
I wanted to mention that I do see Amy Burns has raised her hand, so just.
sure.
Oh, I was waiting. I was going to nominate somebody.
Oh, okay, sorry, Amy.
All right, we will come to you in just a quick sec, Dr. Burns. To that point, now having a vacancy for the vice chair position, members may nominate themselves or another member. Once nominations are received, I will ask if there are any other nominations, and we'll close that vote, and we will go from there similarly. I believe in sequence, it was Dr. Burns, Robert Judge, and our new chair, Shelley Bailey. So Amy, Robert, and Shelley, please.
I nominate Robert Judge.
Right. And
Um,
Robert,
Two comments. I nominate Amy Burns, but my second point is I would respectfully decline to be up for nomination for that role.
and Shelley.
I guess I did want to ask though, Robert Judge, you had your hand up, so I appreciate the decline of the nomination for vice chair. Did you have someone you were wanting to nominate as vice chair?
Oh, yeah, I nominated Amy.
Oh, you nominated
Burns, yeah.
Amy
Mhm.
Burns. Okay, sorry, I missed that. And
Mhm.
I was going to, I guess I'll just go in order of, Mr. Murray, if you want to, please go ahead.
Thank you. I would second the nomination for Amy Burns.
All right, let us pause and ask Dr. Burns if that is a nomination she would be willing to accept.
Yes. Thank you. I wasn't expecting that, but thank you for the nomination. Sure, I'll accept that.
All right, with that said, procedurally, I think we are completing this exercise as we are supposed to. Melissa, given she has accepted that nomination, would you please call the roll for a vote to nominate or rather to elect Dr. Amy Burns as vice chair of the Oregon Prescription Drug Affordability Board?
Amy Burns,
Yes.
Daniel Hartung,
Yes.
Robert Judge,
Yes.
Christopher Laman,
Yes.
John Murray,
Yes.
Chair Shelley Bailey.
Yes.
Motion passes.
All right, Dr. Amy Burns, congratulations to you as the second vice chair of the Oregon Prescription Drug Affordability Board. We similarly are looking forward to working with you as the staff and supporting you and Shelley in your leadership and stewardship over our program. So thank you. Welcome to that role and congratulations. I believe, Melissa, we should approve the minutes of the January 26th meeting and then move into my report and a legislative update. Is that correct?
Yeah,
Yes, that's correct.
perfect. Thank you, Melissa, for confirming that. So I just wanted to ask the members here today if you have any changes to the draft minutes from the January 26th, 2024 meeting that you would like to have made. And then if there isn't any proposed changes to the meeting, I would like to call for a motion and a second to approve the minutes.
I would move to approve the minutes as presented, please.
I second.
All right, well, thank you. Melissa, can you please call roll to vote on the minutes from the January 2024, the approval of the minutes?
Amy Burns,
Yes.
Daniel Hartung,
Yes.
Robert Judge,
Yes.
Christopher Laman,
Abstain.
John Murray,
Yes.
Chair Shelley Bailey.
Yes,
Motion passes.
perfect. Thank you, Melissa. I'd now like to call on Executive Director Ralph Magrish to provide us with a program update.
And thank you, Chair Bailey. Good morning again, everyone. I will provide a brief update as we have added a legislative update with Numi Lee Griffith to the agenda, thinking that was an important step for you. I will just update that February 7th, I testified in front of the Senate Healthcare Committee in support of Senate Bill 1508-2 at the time, which specifically, my testimony was in support of our recommendation to lower the insulin cap to $35 and decouple it from the consumer price index. So, board, we should feel very good about that collectively. As I understand it, there will be a hearing in House Health for that bill this afternoon at 3 p.m. We'll also share that rulemaking for the combined fee structure to fund both the Drug Transparency Program and the Prescription Drug Affordability Board will begin with a Rules Advisory Committee on Thursday, March 7th. We'll also share that staff are continuing to work with Myers and Stouffer to plan meetings with carriers, hospitals, and pharmacies around our Senate Bill 192 implementation for the analytic and work plan to support upper payment limits in Oregon to back to the legislature in September. We've also begun preliminary discussions with staff at PEB and OEB and the Medicaid team at the Oregon Health Authority over the next couple of weeks. Can also share that that I have submitted the names of 2 individuals to the governor's office to fill the vacancy created by Dr. Bruno's departure in December and Akil's position, as he's agreed to stay with us until filled. I was contacted by the governor's office just about a week and a half ago, and it was shared that they were hoping to move up and expedite some of the confirmation hearings and appointments in recognition that boards have a business need to fill seats more quickly and avoid quorum issues. So I have in fact submitted those. While we're not certain when those will occur, we're optimistic that it could occur as early as April or May, conceivably could be the June-July cadence. But again, we were asked to do that in their assistance to us and help expediting fill vacancies. And Chair Bailey, that is the end of my report. If I may just go ahead and introduce Numi Lee Griffith, Senior Policy Advisor with the Division of Financial Regulation, to give a brief legislative update. Numi, thank you so much for joining us.
Good morning, everybody. As Ralph said, my name is Numi Lee Griffith. I'm a Senior Policy Advisor with the Division of Financial Regulation. Ralph did ask me to give kind of a quick overview of where things are at in the short legislative session, which is ongoing. This ended up being a fairly busy year for prescription drug issues, so this will take a minute to get through, but I'll go ahead and jump into that. And then if there's any questions on any of the bills, I'd like to hold that kind of towards the end of the presentation, just to make sure I get through all the content. So the first one I'm going to mention, Senate Bill 1508A, which is a Senate bill that was originally introduced relating to the use of quality adjusted life years and other measures in Senate healthcare. This is the vehicle for our for the PDAB's recommendation related to insulin. And so there was an amendment adopted in the Senate Healthcare Committee, which basically fully would implement the recommendations on insulin. That is specifically reducing the copay cap, the month for a 30-day supply down to $35, and also removing the index to inflation. This bill did pass out of the Senate on a 27-3 vote, and is actually scheduled for a hearing this afternoon and possible work session in House Behavioral Health and Healthcare. So that one is moving right along, and I think you're all very familiar with the policy here, so I won't go into deeper detail. Next slide, please, Melissa. So here's a fairly big one, and kind of what I've tried to do is not every bill that we're tracking is DFR. This is kind of restricted to the bills that are specifically related to prescription drug issues and kind of things that have been in discussion. So House Bill 4149, this is started out as a rerun of last year's 2023 House Bill 3013, brought forward by Representative Nancy Nathanson. This is kind of a fairly comprehensive pharmacy benefit manager reform. The bill last year would have placed, would have actually created sort of a minimum reimbursement structure similar to what already exists with respect to open card Medicaid. That did not move through. And this bill, as it was introduced, included sort of minimum reimbursement for dispensing fees, but did not contain anything related to ingredient costs. A lot of that ended up being stripped out of the bill. That there was a perception that some of the elements were more controversial, and so that did not end up moving forward in that form. The committee ended up adopting, these are from the -6 amendments, and kind of what's left in the bill, it's transitioning PBMs from their current registration requirement. It's kind of it's like licensure, but it's lighter. It moves it into licensure. The big sort of the deal with that is that a lot of things in the insurance code attach to licensure, but don't attach to registrants. And so this will significantly expand DFR's authority, among other things, would give us the ability to access records of PBMs to assess compliance. It adds CCOs to the scope of the definition of PBM under the PBM statute. So right now, as we interpret it, the PBM statute applies to sort of state regulated health plans. So that's small group, individual, and large group fully insured plans. Does not apply to ERISA self-insured plans. This will more or less triple the scope of the population covered by pushing it out to all of the Oregon Medicaid members who are covered through a CCO. So that's fairly large. It adds 3 different new data elements to PBM transparency reports. So we started collecting this information. We will start collecting this information this year. There's sort of 4 figures that we're currently going to be collecting, which are related to rebates and the amount of revenue that is retained by PBM. And this is adding a number of different elements, which were all basically drawn from the Secretary of State's audit report last year, related to things like spread pricing. And so it's kind of expanding things. There was something in the original bill which would have required PBMs to report de-identified claims data. That was ultimately removed from the bill, though. Prohibits PBMs from retaliating against pharmacies in a variety of ways for doing things like engaging in the legislative process or submitting complaints to us. And it also adds text, which is explicitly allowing pharmacies to appeal via complaint violations of the PBM statute to DCBS. So that's this one. Next slide, please. So House Bill 42, 4012, excuse me. Clearly I need another cup of coffee, apologies. This relates to a concept called white bagging, and generally this is a practice where an insurer requires a clinician administered drug to be filled through a designated specialty pharmacy as a condition of reimbursement. This ended up being fairly controversial as introduced. It was being brought forward by oncology clinics, independent oncology clinics, basically saying that this practice puts patients at risk by potentially delaying delivery of drugs, and potentially also puts a higher cost burden on the patient, because under this practice, the drugs are reimbursed under a pharmacy benefit instead of under their medical benefit, and there may be different cost sharing limits. That's not necessarily true in all cases. In some cases, the medical benefit might actually be more expensive for a patient depending on where they're at, but that's neither here nor there. Let's see. So the bill as introduced was kind of limited to various chronic conditions requiring clinician administered drugs. It's been narrowed further by amendment in committee, and it's very specifically only going to apply to independent oncology clinics, and it excludes hospital affiliated clinics, including those that are related to oncology services. A number of the insurers did bring forward sort of the opposition to the original bill, arguing about the very high clinical markups on physician administered drugs that are put in place by hospital pharmacies as being a reason why this practice is there. So that did pass out of the House committee, scheduled for a House floor vote tomorrow. And the one other thing I'll mention, moving back for 1 second on 4149, the PBM reform bill, that is moving to Ways and Means because there is a DFR fiscal to staff the additional regulatory requirements on PBMs. Moving right along, next slide, please. 4113, this is another sort of wonky thing related to copay assistance, manufacturer coupons, etc. And kind of the easiest way to say this is this bans a practice that some parties have referred to as copay accumulator programs. This is a sort of an insurance benefit structure where the insurer or the PBM does not count the value of third-party payments, such as manufacturer coupons, against an enrollee's cost-sharing limit. So the deductible, out-of-pocket max, co-insurance, etc. And there's an argument that this effectively makes people pay twice for drugs, and that there's controversy about this because insurers will, of course, say that, well, this is undermining our ability to use formularies to direct people towards lower cost options. Because what often happens is a coupon will be offered for a very expensive brand name drug, and then that steers potentially the patient towards that brand name drug, which is more expensive for the system because they're able to not pay the copay. You know, there's arguments on both sides about this, really. The bill, as passed through the House, incorporates the -3 amendments, which remove PEB and OEP from the bill. As it was introduced, it would have applied to state-regulated commercial plans, PEB and OEP plans. The amended bill only applies to state-regulated commercial plans, again, that's small group, large group, fully insured, and individual plans. And also similar to a version of this that was introduced last year, which was, I believe, Senate Bill 565, the successor to Senate Bill 560 from 3 years ago, which was much broader, would have applied to all drugs. This only applies to drugs where there is a generic equivalent. So potentially kind of reducing the concern about steering. I think there's still some ambiguity here in terms of thinking about biologic products specifically, and whether this would extend to instances where there is a biosimilar that's common to the market, and if that would apply. But I think that's a battle for another day, perhaps. This bill passed through the House floor with unanimous bipartisan support. There was no opposition in the House. 2 people were excused. So that is a very popular idea with the legislators, certainly. Next slide, please. Let's see, House Bill 4028. This was, so I'm bringing this up. This is a bill that's in the House Rules Committee. The content that I want to talk about is specifically from House Bill 4010, which was one of 2 omnibus bills that was brought forward by the House Behavioral Healthcare Committee. This is related to 340B and specifically contract pharmacies, where this was brought forward by proponents who were representing FQHCs specifically. So Oregon Primary Care Association and sort of similar interests. And really what this is about is a practice that has come up with drug manufacturers limiting the number of contract pharmacies that the clinic, the FQHC is allowed to dispense through, as opposed to their internal clinic. The argument being basically that the drug manufacturers are trying to evade the lower profits they get from having to dispense to retail pharmacies at a 340B cost. The bill was, this element was controversial, and certainly 340B is something that even gives me a headache every time I talk about it. So there was not the energy to move it forward in in-house healthcare. So it was removed from 4010 and is introduced by amendment to this bill 4028, which is a placeholder bill in House Rules. So that is where that is at. The House Rules Committee is not subject to the sort of regular hearing deadlines that apply to normal policy committees. So they didn't have there's no work session posted on this right now, so I don't have a good sense on whether this is going to be moving forward or not. Next slide, please. So that was all of the bills that we had, which were specifically directly related to prescription drugs. I just want to kind of flag sort of 3 other bills, which are sort of big healthcare ideas that may apply here. This is 4091. Would create a health insurance mandate review committee, basically to look at bills that would require health insurers to cover in a certain way in future legislative sessions and do a sort of pre-session assessment of what the actual costs and benefits of passing such a mandate would be. I think there's some ambiguity about the extent to which this would apply in the pharmacy space, particularly like thinking about things like bills related to pharmacy benefit managers. So there is some potential for this to impact future consideration of bills in the pharmacy reimbursement space. House Bill 4002, which is kind of one of the big hot topics of this legislative session, talking about Measure 110, the decriminalization of opioid and other hard drugs, where there's a lot of discussion about the criminalization side. There's some discussion about the treatment side. There's kind of one thing that we really care about as the insurance regulator, which is there is a proposal in the sort of original framework for this bill, which would bar the application of utilization management, such as cost sharing, or such as step therapy or prior authorization to buprenorphine for treatment of opioid use disorder. And then the last one, which is the most ancillary, House Bill 4130, which was kind of directed towards Oregon's corporate practice of medicine statute, had a lot of discussion in the committee and is kind of generally aimed at this idea of reducing outside money, like private equity, coming into the state and coming into the state health system, particularly. The reason why I think this is most relevant to the pharmacy space is because of the presence of PBMs and insurers that have conglomerated and own pharmacies and kind of other things, and the way that there was a lot of talk about not Optum, but what is the company? There was a lot of talk about one of the big PBMs, which has kind of been gobbling up other healthcare entities in the testimony leading up to the presentation of this bill. So that has moved out of the House Healthcare Committee without a fiscal, so that's moving to the House floor as well. Next slide. And that is everything that I had prepared. I'd be happy to answer any questions on any of these bills or anything that I forgot to bring up.
Any questions from the board? If not, Numi, could you flag or make reference to the House Health hearing on Monday, where during the vote, Rep. Nose, I believe, made a statement that he will be creating a work group of sorts. If you could speak to that for a minute, because I do think there could be some intersectionality with the board's 192 work. And then I think Robert Judge has a question. Thank you.
Yes, there was Monday's hearing for House Bill 4149. Again, that's the PBM reform bill. There was a fairly extended debate, and there was the committee actually ended up going at ease in the middle of their vote on the amendment, because all of the Republicans opposed the sort of consensus amendment, and the Representative Tran also initially registered opposition to the amendment. To kind of clarify, these are the sort of consensus amendments that Representative Nathanson brought over that would narrow the scope of the bill, and that would have sort of the original text, which would have set a minimum dispensing fee for certain pharmacies, specifically sort of community pharmacies. There was a lot of dissatisfaction. There was a lot of concern expressed about the sort of pharmacy closures that we've seen throughout the state and across the country, and kind of concerned that if we don't do something now, that this isn't going to that we're going to continue to see those pharmacy closures occur. You know, like, certainly this is not that ambitious, and so the committee went at ease. They talked it over. Representative Tran updated her vote to be a yes, so the amendment went through and the bill was passed out of committee to go to Ways and Means. So that's, and Representative Nose did say that he was going to be organizing a work group in the interim, most likely meeting this summer, to discuss a number of issues. I think most notably for the interest of this group would be a discussion of sort of reasonable reimbursement for pharmacies. I don't have my notes handy for that hearing, so I don't remember what the list of other topics were, but so that was this Monday's hearing on House Bill 4149. But kind of generally kind of looking at the PBM issue and considering sort of the challenges to the retail pharmacy space. So that's out there, and I would assume that a lot of you and your organizations would be interested in potentially participating in that. So that's something coming up. The PBM conversation does continue, even though the bill that passed is significantly less ambitious than what was originally proposed.
Thank you, Numi. In interest of time, let us go to Robert, and then I think Akil, and then we need to move on to our affordability reviews. But Robert, go ahead.
Actually, you jumped me on the question, Ralph. So I was going to ask about that in cap pharmacy. So I'm off.
No problem. And Akil.
Sorry, my apologies. Everyone had to get this updated system, but I wanted to find out exactly around the Bofrine and the Suboxone treatments in terms of the Measure 110 initiative. How directly is that related to our work? Is it the price of them, or is it them being able to, I'm not too familiar with exactly why that would be the intersection of it.
Yeah, I mean, there's fairly limited intersection. It's something that I included as kind of those last three bills are very ancillary to the consideration of costs. The sort of the elements of what is it, 4002, 2002, the elements of the 4002, the House bill that is related kind of to the Measure 110 stuff. There is a very small component of the proposal which relates to insurance coverage and kind of the potential for the cost to a patient, but it's more about access. It's more about access than cost. So it is very ancillary to the work of this committee.
Okay, I'm just kind of worrying about, like, the Measure 110 specifically is the Drug Policy Alliance, which is a lobbying arm, then being able to take money received from their 340B status to then go out there and push this. It's just a messy thing in which I don't think is really our niche necessarily, but just wanted to throw it out there.
Certainly, yeah. All right. Well, thank you for the questions. And I'm always happy to follow up by email if anybody has any additional curiosity that comes up later. So, and my email is at the top of the slide deck. So if that's shared around as material, that will be an easy way to reach me.
Perfect. Well, thank you, Numi. So I'd like to call on Ralph Magrish and Courtney Whitlock to introduce the affordability review on Ozempic and Trulicity.
Great. Yeah, thank you, Chair Bailey, very much. So just a few kind of introductory remarks. And Melissa, I see our ASL interpreter is in the waiting room. If we can work to get her queued up too, that would be wonderful. Just realizing that she was there. Thank you. All right. So folks, just a few remarks and kind of opening comments as we begin this process today. So you'll recall in 2021, SB 844 created the Prescription Drug Affordability Board to evaluate the cost of prescription drugs and protect residents of this state, the state and local governments themselves, commercial health plans, healthcare providers, pharmacies, and other stakeholders in Oregon from the high cost of prescription drugs. To guide that process, the board adopted OAR 925-200-0010 and OAR 925-200-0020, laying out the various factors to be considered to the extent practicable by the board. In accordance with OAR 925-200-0010, the board selected a subset of 3 insulin products and 12 drugs to prioritize for further review under OAR 925-200-0020. Last month, in accordance with that rule, the board did identify 1 insulin product that may create affordability challenges for the healthcare system or high out-of-pocket costs for Oregonians. Today, the board will begin the process of reviewing the prioritized subset of prescription drugs to identify those that may create affordability challenges for the healthcare system or high out-of-pocket costs for patients in Oregon. So as we begin our process of drug affordability reviews, let me provide a process reminder to board members. In February, March, April, and May meetings, the board will review 12 drugs, 3 per meeting, and at the May meeting, we'll select the final list of 9 drugs. Let me also re-level set our work as it's gained a lot of attention from folks who had not previously tracked it. The board does not have authority to set upper payment limits based on these affordability reviews. These are analytic exercises that are being conducted consistent with Oregon revised statutes and the Oregon administrative rules that govern our work. Our rules state that we will conduct all of this work to the extent practicable based on criteria set forth in statute and additional factors that were identified by the board. Our staff and our board have done just that. To that point, our next round of affordability reviews will not look exactly the same. They will look different. This will be an iterative process as we go forward. Will we continue to solicit feedback and incorporate feedback from interested parties to improve upon these processes? Of course we will. Despite some folks' concerns about our processes, as they have shared through the public comment process, including comments about input from patients and caregivers, net pricing, and other information, we have in fact created a space and an opportunity for all of those things. We have encouraged patients and caregivers to provide input. We have encouraged manufacturers to submit information to the board as it relates to net pricing and rebate information, but have not received any. So we are in fact working with what we've got to the extent practicable. And I would just say, as we get ready to roll into these reviews, I'm exceptionally proud of the work you, our board, has done with this and our staff in supporting you. With all of that, I will turn over to Courtney to begin the affordability review discussion.
Great, thanks, Ralph. And good morning, board. I just want to take a second to welcome Chris to the board. It's great to have you on. I'm looking forward to working with you, and congratulations to Shelley for being the new chair. And thank you, Dr. Burns, for filling in to do vice chair responsibilities. It feels really good to have all of your leadership for these reviews. I know Ralph just kind of gave you a quick overview kind of process, but I also wanted to kind of give an overview from what happened last month, which is the board at that board meeting, we reviewed the insulin products and determined that the insulin product Humulin RU500, the quick pen, was considered to possibly or may create an affordability challenge to the healthcare system. Starting this month and going forward for the rest of the reviews, we're just reviewing the subset of drugs that were identified under the ORR 925-200-0010. Also, you'll hear me say often is the rule -0010 rule. The 3 prescription drugs under review for today is Ozempic, Trulicity, and Shingrix. The board will discuss each of the drugs under review and then make a motion if that drug may create the affordability challenge, and to put that drug on a list, and that those drugs will be fully voted on and implemented as your top 9 drugs in May when all the drugs are reviewed. So to get going, before we jump in, is there any more questions before we start with Ozempic? No? All right. Oh yeah, Shelley.
Thank you, Courtney. I did want to mention, I wasn't sure if this was the appropriate time to mention that we did receive a couple drug-specific public comments. I didn't know if we wanted to share that before we start our affordability review to recognize them. Is that?
Yes, that's
I mean,
yeah. So are we doing public comments right now? Apologies, I don't have my.
No, I don't believe so. I believe we will have space for those comments after the presentation.
Okay, no problem. I just was
Sure.
looking at the agenda and it looked like we would do that first,
Sure.
but sorry for the interruption. And Courtney, if you could just proceed. Thank you.
Not to worry. Thank you, Chair Bailey.
I'm going to share my screen. And again, what I'm sharing is just the document based off of the website that was posted. So starting with Ozempic, again, Ralph had mentioned that these packets are kind of a work in progress. They're a little bit formatted differently than last month's insulin review. One of the things about this drug review is that it incorporates information from the data call from the carriers that was provided to us back in October. So we have a little bit more aggregated information based off of carrier reporting. But overall,
Courtney, may I interrupt? My apologies. I think I was misunderstanding what Chair Bailey was saying, in that we do, while we are not accepting verbal testimony, I do think that we wanted to recognize that the board did receive letters from Novo Nordisk and Regents Blue Cross Blue Shield that were included, I believe, in the packet. Is that correct, Courtney?
yes.
All right, so proceduralists, thank you, Chair Bailey. Thank you, Courtney. Go ahead.
Thanks, Ralph.
Well, is there any discussion that the board wants to have over those public comments? Otherwise, it's just acknowledgement of the comments. Dan, I see your hand up.
Well, I think that there was a comment from Novo Nordisk about some questioning of the validity of the data and some aggregation across Ozempic and Rybelsus with respect to NDCs versus GPIs. And so, there's a lot of data details there, but just, if the report it doesn't go through that clearly, then I don't know how valid the data are. So I don't know if it's a non-issue or if it is an issue.
I mean, again, Robert, before I answer that, I'm gonna go ahead and jump over to you.
Well, I was just going to piggyback on what Dan was saying, because when I was going through the packet, it was Ozempic specific. The letter related to both Rybelsus and Ozempic, and left me with a state of confusion. So maybe some clarity from kind of the policy team can help us kind of understand how to think about this when we could just get into discussions.
Yeah, so when the top 25 was first identified, it was Ozempic and Rybelsus. The issue was that Rybelsus was considered, it's an oral comparative to Ozempic, and due to it kind of being more of a therapeutic alternative comparison, it was removed off of the list and then just put in as the therapeutic equivalent comparison. So that's where that is. And going forward, I mean, again, this is our first time around. There's a lot of things that we learned. A main one is ensuring that drugs are separated from each other. I know it was kind of addressed a few months back, and that's where we kind of took out a handful of drugs that were all grouped together. This was just one that we didn't realize at the time really needed to be separated out until we started going through the review and talking with the clinician that we contract with, that it looks better when it's separated out as a therapeutic alternative. So hopefully that answered your question about that.
Well, I think my question was more about the underlying data, and because their letter suggests that the data provided is not specific for Ozempic, like it's both has Rybelsus and Ozempic, because of the way this is pretty, I think a data analyst would need to look at this. It says, and I don't know if it's true or not, but it's suggestive of there's a aggregation across Rybelsus and Ozempic with respect to the cost data that's in the report. So again, I'm just flagging it because it seems to be, the whole report would be based on potentially inaccurate cost data from certain data providers. That's my read of the letter.
So Brooke,
I can jump in. Yeah. So in the Ozempic report, all the data that is represented is for Ozempic specifically, and not Ozempic and Rybelsus together.
Okay, great.
Yeah. Sorry about the confusion, if there was some.
Perfect.
Thank you, Brooke.
all right. Any other questions or clarification? No. All right, so I'm going to go back to sharing my screen. All right, again, this is all the information cost provided is based off of Ozempic cost. So just again, high overview, Ozempic was prescribed to close to 17,000 enrollees and cost the healthcare system $75 million. Cost to patients, as long as they were on an insurance plan and contributed to deductibles, copay, and co-insurance, was average of $277 and some change. One of the things about the price history, WAC increase was that on average, there was a 4.9 year-over-year increase in price, with 2019, 2020, and 2023 being higher than the cost of inflation, or outpaced the inflation. There was a handful of therapeutic alternatives identified. Again, with the gross spend per enrollee was around $4,439. On average, with the therapeutic alternatives, it was just a little bit cheaper with those for $4,436. So that was just the quick overview. Again, this product is manufactured by Novo Nordisk, and it was approved by the FDA in December 2017. I hope everyone had an opportunity to go through the clinical profile. I'm not going to jump too much into it. It's pretty technical, but happy to discuss any information in it if the board wants to. All right, hearing none, I'm going to just jump to the cost of the healthcare system. So again, overview, we kind of had the aggregate information provided, calling out the commercial plans, Medicaid and Medicare cost. Overall, there's again 16,918 enrollees with 69,000 change claims for a total spend of that 75 million, excuse me. So that's the bulk of the costs to the state. Also provided a little more granular information regarding each of the markets. We have individual, small group, large group, and then the OPEB, PEB and OPEB. And then we provided a graph information kind of to look at it more in a visualization of what the market spread is. So any questions about the overall cost or any additional? Yes, Robert.
Sorry, I'm
Yeah.
doing my hand. On this table here, the far right column, average amount paid per claim, that is before or after concessions? Rebates, discounts.
Yeah, so Barack, I believe this is after discounts. So this is APAC stuff. So this is
Sorry.
APEC wouldn't have rebates, right? So is that right?
I'm sorry, what's the question?
So this is gross. These are gross figures.
Okay, thank you.
So before discounts.
Yeah, sorry, my bad. It was the growth costs. So before.
Oh, there it is. Yep. Can I just have one follow-up question then?
Yeah.
Back on that table. Would that explain then, I think elsewhere in this document, you cite that fee-for-service Medicaid had a net price of $443. So that's reflective of their concession, but we don't have similar breakout for, okay.
Yeah, no, this, we don't have any, cause like with the carriers, we were able to do the, request.
Aggregate?
Yeah, and we don't have that, authority to do, do Medicaid.
Probably should have known that answer as soon as I opened my mouth.
Okay.
Thank you.
Yeah. Is there anything else within this packet that the board wanted to discuss before you start discussing about?
Courtney, we have Dr. Burns, Dr. Hartung, and Chris, also a PharmD. I get to say doctor now. Noting that I think Dan has to depart shortly. If we could go to him and then the other two. Thanks.
All right, thanks.
Yeah, just a quick comment before I leave. Just in terms of just looking at if you could go to the page with the costs to the healthcare system. Yeah, right. That top table there. Just a note that, these are averages for the year per enrollee, and then there's average per claim. So, if the average per claim, which I presume is close to about a month's supply, is $1,000. The average for the year is 4,000. So, there's going to be people, this is an average across all people. So, on average, some people appear to be filling like just 4 times a year. So it's not complete therapy for the year. So you can imagine if someone's going chronically for the year, the average cost for that employee or enrollee would be like $10,000 to $12,000. So I guess 2 points. You know, some measures of variation in these costs would be helpful in understanding the variation in cost for the patients, as well as perhaps a better metrics around central measures, measures of central tendency like median or something like that to capture extremes in costs and things like that. So there's probably likely going to be people who are, the cost of them is going to be $10,000 to $12,000, a non-trivial number. So so just to note in understanding these figures a little bit more, and that's it.
Great. Thanks for the feedback, Dan, and thanks for participating. Now you have to get going. All right. Chris.
My question was actually going to be along the same line, Courtney, is, you know, if it is a monthly prescription that they're filling, why were we seeing, you know, the average per claim is 1,000, but the average for the year was 4,000? I mean, I didn't know if they were 90-day prescriptions or, you know, 1 month prescription. So I was going to call out something similar to what he just brought up.
Yeah, and it is a good point. And again, we'll continue to work with the data components as we can with this. Again, just as trial and error and just trying to make it the best with the information that we have. But it is a good call out and something that we'll continue to improve on in the next material information. Amy, did you have anything, or was that covered by Dan?
Yeah, I'm good. Thanks.
Okay. All right. So I'd like to turn the conversation back to the board to start discussing. I'm happy to keep the screen showing if you want me to scroll up and down or provide any other information, but I think this is the opportune time for the board to start discussing how you want to look at this, if it may create an affordability challenge to either the healthcare system or out-of-pocket cost.
Dr. Burns.
Yeah, I'll start. I think this is probably a good medication to look at. We're looking at 2022 data, and I guarantee you that 2023, we're going to see a higher utilization. I know that we're limiting this to Ozempic, and it's good that we have scope clarity here, but I will point out that as we talked about Rybelsus before, there's also Wegovy out there, all the same medication. And there is some fluidity in how people use these medications. This is indicated for type 2 diabetes, but there are some clear cardiovascular disease benefits to using this medication. As you can see, cardiovascular risk reduction in folks with type 2 diabetes. So the amount of population in Oregon that are going to use this medication, continue to use this medication, be started on this medication, is just going to grow. And the list price and the out-of-pocket, if one was to try and pay for this without insurance, is pretty cost prohibitive. So I think that this is a really good medication, this particular class in general, but this medication is a great one to look at. So I'm just going to throw that out there.
Mr. Judge.
Yeah, piggybacking on what you're saying, Amy, you know, there's a secondary use of this drug for weight loss management, you know, and we've all seen it in the media, just the, you know, tremendous impact that has, even though it's off-label. But we all know that off-label prescriptions, that's really the prescriber using their judgment on whether to prescribe a therapy or not. And, you know, much of the, you know, weight loss management isn't widely covered amongst commercial carriers, at least. I don't believe it's covered under Medicaid. So, you know, the consumer is going to be the one carrying this cost if this is a drug that they not only need to control their type 2, but use it for weight loss management. So I think it's a great candidate for some closer inspection.
Any other feedback from the board to discuss, or is anybody ready to make a motion on this?
I'll make a motion. I'll make a
right.
motion to study that. I'm sorry, what is the correct language, Shelley, that I'm supposed to say?
Yeah, and maybe we could share it on the screen.
Yeah. There you
Perfect.
go. Melissa just popped it up.
Yeah,
Okay.
thank you.
I make a motion to include Ozempic on the list of prescription drugs that may create affordability challenges for healthcare systems or high out-of-pocket costs for patients in Oregon.
I second.
All right, well, with that motion and with the second, then Melissa, I'd please ask you to call a roll to go ahead and vote on including Ozempic on the list of drugs that possibly have affordability challenges in Oregon.
Amy Burns,
Yes.
Daniel Harton. He had to leave for his class. Robert Judge,
Yes.
John Murray,
Yes.
Christopher Laman,
Yes.
Chair Shelley Bailey,
Yes.
and Akil Patterson.
Abstain.
Motion passes.
Perfect. Thank you, Melissa. I'd now like to call again on Ralph Magrish to introduce the affordability review on Trulicity. Ralph, we cannot hear you.
Thank you, Chair Bailey. We will go right to Courtney to lead us into the Trulicity review.
All right, thanks, Ralph. So again, I'm going to share my screen. All right. Similarly to Ozempic, we had the overall review cost of 125.5 million across 24,793 enrollees. With that were, oh, sorry.
Sorry, I would just like to kind of step in for a moment to be consistent with what we did on our previous medication. I do want to make sure to mention that the board did receive the following drug-specific comments related to Trulicity. So we received Trulicity letters from Cynthia Ransom of Eli Lilly and Company, and we received that letter on February 19th of 2024. But we do not have any Trulicity speakers at this time. Ralph, did you want to add anything?
Nope, couldn't have said it better myself, Chair Bailey. Thank you.
Perfect. Thank you, Courtney, and please continue.
All right, thanks for the correction. Again, so cost to the patients on average was $401 and change. Again, with WAC pricing increasing year over year, we're at a 5-year span of 5%. With that price outpacing inflation in 2019, 2020, and 2023. There was 4 therapeutic alternatives for Trulicity with the average spend per enrollee of a little over $5,000 with around 4,436 with therapeutic equivalents. For the patient out-of-pocket cost, per patient per year was around $296, and that in comparison to some of the therapeutic alternatives, they were a little bit higher at 329 or 328. And this drug is manufactured by Eli Lilly and Company and was first approved by the FDA in September of 2014. Again, clinical profile is extensive with information about the drug. And then costs to the healthcare system. I will stop here to see if the board wants to continue any discussions around costs and pricing for this. I'm pretty sure it's kind of the same where with the Trulicity. So we'll continue to look at those numbers, you know, averages versus means and stuff. But Robert, go ahead. Oh, you're on mute.
Thank you. You know, this is another GLP product, and you know, as Amy indicated earlier, that this class of drugs is a bit challenging, both in terms of what they mean, in terms of the patient burden that these drugs deliver while they provide care, but as well as the kind of the payer side of this thing. So GLPs, Trulicity would be just another drug that I think we need to kind of take a look at.
Yes, and I believe that down in the therapeutic alternatives, they were kind of all compared. Yeah, so Trulicity, Ozempic, Rybelsus.
Mhm.
Yeah, and then we broke it out with more gross healthcare versus out-of-pocket cost. Yeah, John.
I was just going to comment from a community pharmacy perspective, these medications the cost is hard for patients to pay. We are seeing from a pharmacy perspective, as far as contracts go for providing service on these medications, they're actually being broken out specifically in contracts. And while I won't mention names, of course, that's the anticipated and actual impact to the healthcare, to the pharmacy delivery system that we're seeing. They do have a tremendous benefit, whether it's the primary indication or their secondary or unapproved. They do have that benefit, and that's why they're being used. We're seeing worldwide demand influence the availability of the product in local community pharmacies, particularly this medication. So yes, they present a challenge for patients to afford. While their benefit is, in my opinion, tremendous, the cost is also tremendous.
Hey, Kayla, I see your hand up.
Yeah, so my question more revolves around like usage. Does this say, like, is it just simply for the type 2 diabetes, or is this being used primarily for weight loss? Just like the Ozempic, I think that's kind of one reason why I was a little bit of an abstention is that there are the cosmetic reasons in which people are reaching out to ask to see about using these, and then there's the livability reasons and health concerns. So that's kind of where I'm asking.
Yeah, this may be better answered by a clinician, but in the report, it is indicated for type 2 diabetes management, but it is utilized as a weight loss drug. But Dr. Burns, do you have any additional clarification on this drug?
Yeah, it would be really difficult for us to be able to pull that out of the all payers, all claims data. In general, the way that prescribing practices work in the United States is that as long as it's on the market, a prescriber and it's within their scope, they can prescribe a medication for any indication that they want to. That said, one of the reasons that there's this additional indication for both Trulicity and Ozempic that revolves around cardiovascular risk reduction is that seeing that overall weight loss and that drop in, and if you look at, again, not Ozempic or Trulicity, but their sister drugs like Wegovy, which is the same active ingredient as Ozempic, there are pretty there are guardrails on what sort of BMI this would be effective in and for what kind of weight loss that you could see. And from seeing that weight loss reduction, especially in people who have a cardiovascular, like either primary or secondary risk, you can really see the benefit from that. So I guess the short answer is no, we don't know if they're using it for type 2 diabetes or for obesity. But I guess my argument would be the long answer is that I'm not sure if that matters.
Okay. I mean, I think there's obviously, again, the cosmetics situation versus the medical side. And that's kind of where, I was just kind of asking, but thank you.
And Mr. Judge.
Yeah, I will add that, if it's a covered drug under some payer plan, there's generally criteria that have to be met for the prescription to be at least paid for. So, and at least what I'm familiar with, we have diabetes as the indication for these types of drugs. They're not authorized for weight loss management because they don't have a FDA authorization for that. So they're really off-label use. The point that I wanted to make, though, that was just an average of what the conversation was. I think we'd be remiss, these are pretty expensive drugs. We'd be remiss if we didn't acknowledge the fact that industry is providing copay coupons to help individuals, cover their burden on the cost. We heard Numi talk about a little earlier today about kind of the challenges with that relative to trying to do formulary management, utilization controls. But the copay coupons really do help individuals cover the cost of the drugs. The problem with that is copay coupons are completely capricious, might not be too strong a term. They really exist at the decision of the manufacturer. And so they could be here today and gone tomorrow. So there's no really sustainable guarantee that a consumer has in the use of copay coupons to cover their burden.
And Mr. Judge, I guess to add on to that, I guess I would just also like to make sure to reinforce to your point, we're aware that there are manufacturer copay cards available. We're also, I think in one of our letters, we're informed that there are support, diet and lifestyle, digital support solutions that are available to help people from manufacturers. And then again, I'd just like to highlight that we're making we're voting on these issues, understanding that we don't have net pricing, right? And so as Ralph kind of mentioned previously in the meeting, to the extent that we get better and quantitative information that we can use in the future with our affordability reviews, that is meaningful and appreciated. But for now, we have to do the work we do, acknowledging we don't always have net price information.
With that said, though, Chair Bailey, I think that tees up Courtney for this next piece of the discussion, right?
Yeah, so I'm showing this. This is from the data call or the carrier information that we receive, where it kind of provides somewhat of a gross breakdown to the net cost of the drug to the state during 2022. So you have a little bit of a visualization to what that looks like. Again, these numbers are aggregated across all carriers, and of course the rounding to consider as well. So, but it gives you kind of the ballpark of the impact between the carriers and even what CCOs paid down here. So yeah, the packet has, a little more detailed information than like what the insulin packets did last month because of the added data call carrier information on it. But if there's nothing else that the board wanted me to show in the packet, I'm happy to turn it over for a vote or a motion or any other discussions the board would like to have.
Mr.
Courtney, when I was staring at this, I was the colored blocks. I was really struggling to try to understand it. And so based upon what you're saying is that if we look at concessions being 100%, the net cost post concession is what, like discounts at the point of sale? And then manufacturer concessions are rebates? PBM concessions are passed through, or what are I was trying to understand how to, and they're all some discount off of 100%. Right?
Yeah, that's the association. It's some form of a discount was provided to the drug, whether through manufacturers, PBMs, or through the net cost.
Can you help me understand or distinguish between a manufacturer concession and a PBM concession?
I may have to call Breck, since he's our data analyst, to kind of clarify the graphic information. Thanks, Brock.
Hey, Robert. So thanks for the question. So, Courtney, can you scroll up a little bit? So this is an easier table to kind of think about things through. So it's just stay there, Courtney. So if you see that 4,792, That's the average spend per enrollee, pre-concessions. And then the 2,314 is once you get that 52% haircut. So
Right.
that's sort of the net spend on the drug.
Mhm.
And so if you go down to that table again. So in other words, the 2,300, I can't remember what the number was, but the 2,300 is the 48%, that blue box
Right.
there. So all these boxes together, kind of like the gross cost, and then as you take those different concessions out. Now, unfortunately, I can't speak to the details of how the concessions work with regards to like, okay, the PBM concession comes in this way, the manufacturer concession comes in this way. This is the kind of how the data was reported to us, but you can kind of think of it as like the net cost is that 48% or the 2,300 per enrollee. And all those boxes combined, the 48%, 34%, 17%, so on, that makes up the, 4,000, again, I can't remember the numbers, but those numbers above 4,792. I hope that clarifies a little bit. I apologize that I can't get too more detail to the PBM and manufacturer discounts.
That's really helpful for me, between the kind of the pea green, at least on my screen, and the orange, those represent the discounts.
Exactly. Yeah.
Okay, got it.
Yeah, and we will work hard to make this a little bit more intuitive for next month. I apologize that wasn't super clear.
Look, but thank you for that.
Of course.
Great, thanks, Brock. Any other questions or clarification needed before motion? All right, I will pass it over to Chair Bailey to.
Perfect. Thank you, Courtney. Yeah, I guess I would just like to ask the board today if anyone wants to make a motion to include Trulicity on the list of drugs for that may present affordability challenges in Oregon. Mr. Judge?
Yeah, I want to make the statement first because, I realize that I work for a health insurance company. I'm stating this not because of my position in a health insurance company, but my position as a board member here, just looking at the data as it relates to what members are paying. So based upon that, with that kind of as my fourth statement, I'd recommend, I don't know the language that.
Oh.
There.
Press.
Yeah, I'd make a motion to include Trulicity on the list of prescription drugs that may create affordability challenges for healthcare systems or high out-of-pocket costs for patients in Oregon.
I'll second that.
Okay, well, with a motion and a second, Melissa, if you could please call roll.
Amy Burns,
Yes.
Daniel Hartung has gone to teach his class. Robert Judge,
Yes.
Christopher Laman,
Yes.
John Murray,
Yes.
Akil Patterson,
Abstain.
Chair Shelley Bailey.
Yes.
Motion passes.
Well, thank you, Melissa. I would like to now announce, I guess, a 5-minute break. So we'll see everybody in 5 minutes.
And Chair Bailey, if we could ask members to turn their cameras back on or raise their virtual hand to affirm they are back if they're more comfortable doing so. Thank you.
Perfect. Thank you, Ralph. Yep, I'd like to ask the members of the Drug Affordability Board to either turn your camera on or raise your hand to acknowledge that you are back in the meeting. I see that we have Mr. Robert Judge, Mr. Laman, Mr. Murray, myself, Ms. Burns, and Mr. Patterson, all here back at the meeting. So with that said, I'd like to call on Ralph Magrish to introduce our affordability review on Shingrix. But I guess after you do that, Ralph, I'll also acknowledge the letters we received.
Yes, and Chair Bailey, if you may, go ahead and if you'd be so kind as to speak to those letters. And I believe we have 2 speakers signed up, and procedurally those will be limited to 3 minutes, if I understand that correctly.
All right, thank you, Ralph.
Each. Yes.
Absolutely. So to acknowledge the letters that we did receive, to your point, we received 3. We received 1 from GSK from Harmeet Dhillon, Head of Public Policy. We received that on January 31st, 2024. We received a letter from GSK, again, I guess, from Harmeet Dhillon, Head of Public Policy, received on December 8th, 2023. And then we received a 3rd letter from the Safe Communities Coalition from Northeast Sanders, the Executive Director. So we do have 2 speakers today. Our first speaker will be Corey Greenblatt, Global Healthy Living Foundation. Corey, if you could please keep in mind our maximum 3-minute time limit. You have the floor.
Good afternoon, everyone. My name is Corey Greenblatt. I'm commenting on behalf of more than 1 million chronically ill patients living in Oregon and the thousands of patients who rely on Shingrix and similar vaccines to protect their health, whom GHLF represents. Thank you for allowing me to comment today regarding Shingrix and its affordability. While the effort to reduce drug prices is one of the most pressing concerns in our current healthcare system, we believe that any measure that would reduce the accessibility of life-saving drugs would have disastrous effects on patients in the state. For this body to be considering a vaccine is extremely worrisome. Prior to being released into the market and available to be covered by insurance, vaccines are required to go through an exhaustive cost effectiveness and economic value assessment process by the Advisory Committee on Immunization Practices after receiving FDA approval. Additionally, due to federal mandates in the ACA and the IRA requiring coverage for all CDC recommended vaccines, many patients have minimal out-of-pocket costs before considering federal safety net programs that provide free vaccines for underinsured or uninsured patients. Beyond looking at the cost effectiveness or insurance coverage of vaccines, we must acknowledge that they are a specific type of medication that is separate from other life-saving medications under review. Unlike medications that treat a specific type of disease or range of diseases, once someone has already contracted that treatable disease, vaccines are all about preventing that from being necessary. We must consider that high utilization of vaccines and preventing the costs associated with the diseases that they prevent is entirely the point of vaccines. They should not be subject to affordability reviews based on high or increasing utilization, as this conflicts with the public health goals to increase immunization rates as a prevention tool. Additionally, I would like to make a quick comment on the medications you were reviewing earlier. Ozempic and Trulicity are paramount in the pharmacological arsenal against type 2 diabetes, offering revolutionary approach to glycemic control. These medications presented a noteworthy shift with their convenient once-weekly injection regimen. Beyond the fundamental glycemic benefits, the supplementary perks of weight loss, mitigated cardiovascular risks, and heightened insulin sensitivity underscore their significance. Any inclination toward restricting access to them, which could well occur because of this board's decision, warrants extreme scrutiny, considering the potential ramifications on patient outcomes. More so, the implications extend beyond diabetes management, as these medications demonstrate substantial efficacy in addressing obesity, making them indispensable for a broader spectrum of patients. The intersection of diabetes and obesity underscores the importance of maintaining unimpeded access to these medications and ensuring comprehensive and effective approach to metabolic health. We appreciate that you are taking the steps today to listen directly to the patient and the caregiver community, but we want to ensure that this listening session is not just a box to be checked off. We want a more transparent process that doesn't end in a series of listening sessions. Patients are the ones who will ultimately.
Thank you for your comments.
You're very welcome. Have a good day.
Thank you. And we'd now like to ask Mr. Leonard Friedland from GSK to please have the floor. And again, please keep in mind the 3-minute time limit.
Yes, hello, can you hear me?
We can hear you. Thank you for confirming.
Good morning, members of the Oregon Prescription Drug Affordability Board. My name is Dr. Leonard Friedland, Vice President and Director of Scientific Affairs and Public Health for Vaccines at GSK. I will start by bringing to the board's attention that the board's affordability review that was posted on February 14 states on pages 8 and 9 that the Shingrix package wholesale acquisition cost is $1,834. It's important to point out that each package includes 10 doses of Shingrix, which means that a single dose of Shingrix is $184. An estimated 1 million people get shingles each year in the United States, and 1 in 3 people will get shingles in their lifetime, making prevention of clinical importance for health and wellness. GSK Shingrix vaccine is more than 90% effective in preventing shingles in adults 50 years of age and older, and it provides long-lasting protection. The CDC recommends that all adults over age 50, as well as adults over age 19 with immunocompromised conditions, receive Shingrix. There is no alternative prevention option for shingles, which makes unencumbered access to Shingrix critical for Oregonians. All CDC recommended vaccines, including Shingrix, are covered without cost sharing for the majority of publicly and privately insured individuals. Federal safety net programs provide access to vaccines without cost sharing for uninsured and underinsured individuals. And in addition, the GSK Patient Access Programs Foundation allows us to help eligible low-income uninsured patients access medications, including Shingrix. For this, the patient, therefore, has virtually non-existent out-of-pocket costs. Supporting vaccine access and uptake reduces long-term healthcare spending and is one of the most cost-effective ways to improve health. High utilization of a vaccine, such as Shingrix, and preventing associated medical costs is the goal of all state immunization programs. I want to point out again that the Shingrix package includes 10 doses, which means a single dose of Shingrix is $184. Vaccines are reviewed and undergo cost effectiveness and economic value assessment by the CDC's ACIP committee before they're recommended by CDC and are then covered by public and private insurance plans. In its analysis of Shingrix, the CDC found the vaccine to be cost effective. In 2021, the Oregon Health Evidence Review Commission found CDC recommended vaccines to be effective with regards to cost and clinical effectiveness. For these reasons, we asked the board to find Shingrix affordable for Oregon residents and ensure continued broad access and uptake. Thank you for your time.
Thank you, Mr. Friedland. I would now like to ask if the board would like to discuss Shingrix as we did with the other medications.
All right, thanks, Chair Bailey. I'm going to share my screen again.
Thank you, Courtney.
All right, and thank you for the comments from public. So again, we're reviewing Shingrix for affordability. Review summary indicates that 13.5 million Oregonians had access to it, apologies. So Shingrix had a 13.5 million spend across 55,578 enrollees, with an out-of-pocket cost gross spend of $242.89. Yes, the average cost to a patient was considered to be approximately 50 cents. Again, this is on average, but also noting that there has been a WAC increase over a 5-year span of 5.6%, with the outpace of inflation in 2019, 2020, and 2023. Manufacturer is GlaxoSmithKline and was FDA approved in October of 2017. Again, clinical profile was significant in understanding the concepts of Shingrix as a vaccine and understanding there's no therapeutic alternative to this vaccine. Looking at cost to healthcare, again, significant spending on their total spent of 13.5 million, with a total of 84,225 claims. Again, WAC, manufacturer WAC increase starting in 2018, the 5.5% increase. The 2019, 2020, and 2023 being exceeding the rate of inflation. There is a low cost to patients, and I just wanted to note for Shingrix that it was not associated with the data call to the carriers, so we do not have any price concessions of this drug at this time, and unfortunately it was left off of the list during that data call. I know this is a short packet, but hopefully there's enough information for the board to have a discussion around for the total cost to the healthcare system. So I'm going to turn it over to the board for any other discussions or for motion.
So is there anyone here that would like to add anything or have any general discussion before we proceed with if we're voting on this medication or not? Mr. Murray.
In the information that was presented to us, it mentioned as of January 1st, 2024, the WAC price increasing 7.9% versus the 5.6% in previous years. How does that compare with the rate of inflation as of January 1, 2024? I'm a firm believer in vaccines, and I've seen the benefit of this vaccine in particular and encourage its use all the time. So I will be hesitant, honestly, to put forward this medication where it's ACIP approved and gone through that process. So if I could just get that information about the percentage, that if it exceeds inflation again, I guess that's the only, apologies, the only thing that I have, a problem that I have with it is that it's known to be effective, it's known to be approved and paid for by everyone, but the cost exceeds inflation every single year or nearly every year. That's problematic for me. But the benefit of the vaccine is definitely there. Thank you.
Thank you, Mr. Murray. Mr. Judge? Mr. Judge, we cannot hear you.
So I think there's two observations here. One, I share the concern of kind of lumping a vaccine into an affordability review, especially since the data packet is light. I don't see anything here that's that points a finger in a direction that says this is concerning, despite the fact that we've had kind of year-on-year inflation that that exceeds the CPI index. That's troubling. But I think the data on the benefits of this drug, the fact that there's no peer to this drug, the fact that it's a much more effective treatment than what pre-existed, Those are all really good factors, and that the fact that it's widely covered by carriers doesn't point a finger to me that says the patient bears an inordinate burden on this drug. So I can't logic an argument in my head that says, it should go into an affordability review.
Thank you for that, Mr. Judge. Is there anyone else that would like to share any perspective related to reviewing the information on Shingrix?
Chair Bailey, I have just a brief comment if that's okay.
Absolutely, Mr. Laman.
Yeah, it's a subjective comment more than an objective comment, but I mean, working in a rural pharmacy and filling prescriptions, I have lots of conversations about medications and how patients are going to afford them on a monthly basis, but access to this vaccine in particular has not been one of those conversations. I mean, it is widely covered, and I feel available equitably to people who are coming into the pharmacies. And I can't speak to the medical clinics, but at least in the pharmacies to receive it. So it's not something that I consider something that would need to be part of our work.
Perfect. Thank you for sharing that, Mr. Laman. So I guess I will call it out to the board to see, is there a motion to include Shingrix on the list of drugs that present affordability challenges in Oregon? So I don't not hear a motion via audio, and I don't see any raised hands. So I guess my observation would be that we do not have a motion to include Shingrix on the list. So I guess it's my understanding that we simply move on to the next agenda topic. Is that correct, Mr. Magrish?
That is correct, Chair Bailey.
Okay, perfect.
And if I may just thank the board and for your work in this endeavor and for voting what you thought to be appropriate. So we appreciate your efforts, and you did what you were tasked to do. Thank you.
Absolutely, thank you. So moving forward, this portion of the agenda is for the general public comments submitted or requested in advance. The board received 5 general written comments, which are posted on the board's website. The board received 2 requests to provide oral testimony today. I'll reference the letters first, and then we'll move forward with the oral testimony. So the letters that were received were from Kendall Boyer from the National Infusion Center Association related to provider reimbursement. We received letters from Sandra Gukian from the National Association of Chain Drug Stores related to vaccine eligibility and upper payment limit actions. We received a letter from North Saunders from SAFE related to vaccines. We received a letter from Daria McGrew from Pharma related to the February PDAB meeting. And then a letter was received from Brian Mayo at the Oregon State Pharmacist Association. So I now call on the individuals who signed up to provide oral testimony and ask you to please state your name and organization before you speak. You each will have 3 minutes. So again, as a reminder, the board will not deliberate on any issues or requests during the general public session. And so Melissa will now be opening the mic and providing the floor to Susan Will Schwartz from the Global Coalition on Aging related to vaccines. Susan, welcome.
Thank you. Thank you to the board for giving me the floor. My name is Susan Walsh Schwartz, and I'm here today on behalf of the Global Coalition on Aging. At GCOA, we are committed to supporting a policy environment that enables healthy aging and societal inclusion for older adults. GCOA would just like to follow up on the discussion about Shingrix to raise an objection to vaccines as a category for examination under Oregon's affordability review process. And this is for several reasons. First, as Mr. Greenblatt and Dr. Friedland already mentioned, vaccines already have to clear several hurdles at the federal level through the CDC before they even make it onto Oregon's vaccine program, which includes the ACIP's assessment of cost effectiveness. Aside from this, the ACA and IRA mandate vaccine coverage without passing costs on to the public. So there's essentially no public affordability concern. It's an important fact, which has also been recognized by the speakers and the board just moments ago. And secondly, I'd like to also raise an objection on public health grounds. Childhood vaccines are widely recognized as one of the greatest public health achievements of the 20th century and are in large part responsible for our longer lives that we now enjoy. We're in the midst of a major demographic shift to more old than young, with all kinds of implications for our health systems and fiscal sustainability. Vaccines are one of the most cost-effective tools we have to support healthy aging and reduced healthcare spending by keeping people healthy, productive, and out of the hospital, even as we age and our immune systems become less effective. Oregon's population aged 65 and older is growing at a faster rate than that of the nation as a whole. The average age in Oregon exceeds that of the national average, and the number of Oregon residents 65 and older has increased 32% just since 2010. Amid increasing pressures to spend smarter and invest in prevention, we believe that all governments, Oregon's included, must prioritize widespread vaccination for all ages, and especially older adults, where the largest immunization gaps exist, and there's an equity issue. Placing vaccines in a category for additional scrutiny directly conflicts with this growing imperative, and I find this particularly concerning for a rapidly aging state like Oregon. Thank you.
Thank you, Ms. Schwartz. We'd now like to call on Daria McGrew from Pharma, specifically related to her comments on the February PDAB meeting. Again, Ms. McGrew, please keep in mind the 3-minute time limit. Welcome.
Hi, good afternoon, Vice Chair and members. Thank you, Daria McGrew, on behalf of Pharma, commenting again. We continue to raise concerns about missing mandatory considerations as well as inconsistency in your analyses. Firstly, the board took great care and time to develop a list of criteria in your rulemaking that would be considered to the extent practicable. We did ask at the time that the board clarify what data sources would be used for these considerations. If it turns out that there are not the data you'd like for this analysis, then we ask that that be clearly stated and explained in your reviews. You haven't considered equity this month, although some metrics were included last month. And again, there wasn't any analysis of the burden of disease, which is well studied and widely available. Additionally, inconsistencies between affordability reviews have not been clearly explained, such as which drugs were included in carrier data call and which were not. For folks that are not following along extremely closely, that is not clear in your reviews. We recognize that you are developing some of this as a new program and that there may need to be iterations, but at the same time, you are taking votes as you go, and this is concerning. These reviews are not treating all drugs equally. We ask that you not continue to perform these reviews or not continue to take votes on these until you have clarified these inconsistencies and are able to treat all drugs equally. Thank you.
Thank you, Ms. McGrew. So with there being no further business before the board, we do need a motion and a second to adjourn the meeting. Does any, Mr. Murray, it sounds like I'll let you proceed.
Yeah, I'd make a motion to adjourn.
I'll second.
All right, well, all in favor, please say yes.
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 Any opposed, please say no. All right, well, with that, I'd like to thank everyone for their time today, including all staff, board members, and those who provided public comment. And the meeting is adjourned. I was intending on stating the date and time of our next meeting and realized I did not include that on my notes. I believe it is on March 20th at 9:30 a.m. Pacific. So thank you again, everyone, for being here, and we look forward to seeing you next month.